Today it's my pleasure to be interviewing Professor Lindsay Symon. Professor Symon heads the Gal Cooper Department of Neurosurgery at the National Hospital Queen Square. Lindsay and I have been friends for many, many years. I first met him at a combined meeting of the British Society and our Neurosurgical Society of America in New York. And I remember vividly sitting with him while Dr. Silverstone was showing us a movie on how he was clipping an aneurysm in the posterior communicating region. And Professor Symon and I both winced at the same moment when we saw the clip going in backwards, and there was an eruption of the film, obviously while the mess got cleaned up. But it was interesting, we both winced at the same time. You remember that, Lindsay?
Oh, I remember that vividly, yes. Yes. That was an interesting meeting in many ways because it was my first trip to a neurosurgical convention in the United States. I had been, as you know, for a year in America on a Rockefeller Fellowship sometime before that, but that was my first neurosurgical convention.
You were with John Sterling Meyer, is that right?
I was in Detroit with John Meyer doing cerebrovascular physiology for a year. Very entertaining experience, as you might imagine.
I bet it was. This, of course, has been your interest continuously along cerebral metabolism and blood flow.
I think one of the things that has brought me back to the States time and time again has been the fact that when Brian Jeanette and I started doing investigative work in Britain, we were just about the only neurosurgeons who were at all interested in experimental research. For example, the laboratory I set up in Queen Square was at that time the only experimental cerebrovascular laboratory directly connected to a neurosurgical unit. And I think a great deal of the inspiration for developments in experimental work came from my friends and colleagues in America.
I remember that laboratory very well. It was in the Migran Trust building, and which is sort of catty-cornered across the street from the National Hospital. And every Thursday was an experimental day. It began with taking a cage and a sheet and trundling it down the stairs, across Queen Square, into the lift, up to the top of Queen Square, catching a baboon and putting him to sleep, putting him back in the cage, trundling him back across to the laboratory. The first time I observed all of this commotion, I said to Lindsay, I said, you know, I don't think in the United States we do research under these conditions.
Oh yes, it's quite funny. One of the funniest things, of course, now is that that building is used for office space.
Yes.
And our present dean, John Marshall, who's a very good friend of both of us, sits at his desk in a space which was previously occupied by the baboon operating table, and I've had occasion to remind him of that from time to time.
Lindsay was trained, at least in part, by Valentine Logue and by Wiley McKissick, right?
Well, not really. I never worked for Wiley. I maintained a sort of gentle distance from the great man when I was training because I worked entirely with Valentine. But when I got on the staff, Wiley and I used to share the operating suite on a Wednesday. And so I used to see him work then, and he would come through and see me work, which was somewhat unnerving for a young surgeon. I remember once he came to watch me doing a cloud operation, which was the sort of thing he wouldn't, under any circumstances, become involved in, you see. And I showed him this small hole through which you could see the anterior dura, and he shook his head sadly and moved off, muttering about keyhole surgery and so forth. Not his scene at all.
Not his way of doing things at all. As you might suspect, Professor Symon is a Scot, and as a Scot, he plays the national pastime regularly, frequently, and I must say quite well at times. And we've enjoyed the sport in several continents over the years. And you belong to two clubs in London, the Rye.
Yes, well, Rye's not in London. Rye is actually on the south coast, down near Hastings, really. It's just down between Dungeness and Hastings. That's a links course. And then I have my Metropolitan Club, which is South Hearts, which is actually only about 10 minutes from home in North London, as you know.
Yes, as I know very well. Tell me, Lindsay, I've watched the professor operate many times, and I'm terribly impressed with the speed and dexterity with which he does things and how much he does in a given day. What would you say your favorite operation is?
Oh, that's quite hard to say. I think my favorite operation was, for many years, the excision of supercellular meningiomas, because I have made quite a thing of paracellular tumors for a number of years. I don't do them quite so much now because we have them spread more evenly among the staff. And I suppose my favorite operation now is probably the excision of a small acoustic neuroma trying to preserve hearing.
You once told me that you were concerned about that because you felt that the instance of recurrence might be higher when you have to spare hearing.
Yes.
You still feel that way?
Well, I think only time is going to tell, but we had a discussion about this at one of the seminars of this meeting, actually, and we all feel that there are a certain number of tumors which involve the bone proximal to, or rather distal to the internal auditory meatus. Now, those are probably not the ones that you're going to preserve hearing in any way, because you're going to get into the base of the spiral ganglion just chasing the tumor. The ones in which you can preserve hearing, small, relatively extremely well-defined lesions within the meatus or just within the head, are so well circumscribed that I wouldn't have thought there was too much chance of a recurrence with them. My concern with recurrence is primarily, I think now, with those in which tremendous efforts are made to spare the facial nerve, and there you may be very tempted to leave the odd cell on the facial nerve. And we have, not in my own personal practice, but we've seen reported cases of recurrence, and recurrence a little bit higher than one would have expected from our previous methods of simply coring out the porous, burning everything in sight.
Yes. And how about aneurysms?
Well, I think as you know, my main interest in aneurysms has been to try and convert or try and transfer our basic cerebrovascular physiological insights into the surgery of aneurysms. And there, anterior circle aneurysms are now done as a routine, I suppose, as in many clinics. We use somatosensory evoked response recording routinely, and are developing motor evoked response recording, both electrically and by magnetic stimulation. And that's proved of enormous help. Vertebrobasilar aneurysms, of course, are still a tremendous challenge, and like most units, we see somewhere about 10% of the aneurysm population as vertebrobasilars. And there again, I've found that the use of somatosensory evoked response recording has been very valuable. Some years ago, I think before it had caught on generally, I described the use of temporary clips to produce what is really acute focal hypotension, so that you don't have to drop the systemic blood pressure very far, but you can defuse the aneurysm, soften the aneurysm. I presented that at a meeting in Japan, and I remember Charles Drake, a very dear friend, saying to me, well, if that's true, Lindsay, aneurysm surgery is going to become very easy. And in fact, I think it's been generally accepted now that our old fear of temporary clips is quite groundless, that you can get away with temporarily clipping the circulation, at any rate distal to the circle willis, for periods of 10, 20 minutes. And we find the somatosensory evoked response recording very helpful in that regard, and are still developing the parameters of safety, I think.
Do you use any pharmacologic protective devices like barbiturates or?
No, we don't. I was interested in one of your colleagues' papers on etomidate, which is something that the late Gordon McDowell was very keen on. And we had a good deal of experience of etomidate in head injuries and so forth, undoubtedly a metabolic suppressant, but we've used absolutely nothing. We've neither used the Sendai cocktail nor barbiturates. And I think probably if these add anything, it's very marginal. It's very marginal.
And where now are you going with the cerebral metabolism in your laboratory?
Well, with cerebral metabolism, we are becoming, as you know, we were interested for quite a number of years in the thresholds for ionic movement and established movement thresholds for potassium and calcium. But it became very clear that by the time you had such movement, you were closing the stable door when the horse was long gone.
Oh.
Now we've become very interested in the early pH changes. pH change in ischemic tissue occurs at very much higher blood flow levels than you might suspect. In fact, there is a significant change in extracellular pH by the time you're beginning to get electrical failure. And that means that the buffering capacity of the tissue has by that time begun to be exhausted. And one of the things in cerebral protection that I think is going to be very interesting over the next few years is an attempt to understand the characteristics of this exhaustion of the buffering capacity. Because at that point, before the blood flow has fallen too far, certainly in neurosurgical terms, it might be possible to produce protection. There's still enough blood flow to carry whatever protective agent you've got rapidly to the tissue. And I think this might be quite helpful. I was interested at this meeting to see some selective staining techniques that Larry Pitts had been using in a rat model of middle cerebral occlusion, suggesting that in fact you could, by the metabolic suppression of calcium antagonists, protect the penumbra.
Really?
That mythical entity that we described many years ago.
Yes. What is that penumbra?
It was once disrespectfully described by a good friend of us both as the pen umbrella, because he felt that it was used to explain a lot of hypothetical concepts. But it is a hypothetical concept, actually, just that area in which function is temporarily lost but can be restored. And people say, well, penumbra doesn't exist, but we're all very aware that it must exist, since you can induce the return of function in a post-operative aneurysm by hypertensing the patient. There's no argument that cells do recover. The question of a chronic penumbra is something that has been really much more difficult to establish. And of course, this has been used as the scientific basis for a lot of cerebral revascularization procedures, possibly somewhat optimistically. But there is, again, no doubt that if you look at, for example, the recovery of someone who's had a major artery divided in the course of a neurosurgical operation, the recovery will occur in a very well-defined and orderly fashion. First, the more peripheral areas of brain to the occlusion will recover. The leg, for example, in a middle cerebral occlusion. Then the shoulder and proximal function, then the hand, then the face, and language last. And it's most particularly interesting to me that if you have a bilingual patient, they will recover the language in which they were brought up first, and their most recently acquired language lost, which suggests to me that this concept of selective vulnerability is applicable in terms of neuronal organization as well as in terms of single neurons.
Do you think that this organization at the higher cortical levels, where speech is represented, is more vulnerable than, say, basal ganglia or midbrain or pons to ischemia?
That's something that is a little bit difficult to establish, but our present view is that is so, that the more complex cortical functions are more susceptible to ischemia than, for example, the brainstem or thalamus. We have some experimental work which suggests that is the case. Looking at the vulnerability of cortex compared, for example, with thalamus, we have some experimental evidence that the generation of electrical activity in thalamus is more resistant to ischemia than in the higher centers. That's entirely with somatosensory work, and the same applies to brainstem. So that I think we would need to validate that before I were too certain of it. But it certainly looks as though there is greater susceptibility to ischemia in higher centers than in the basal ganglia or in the stem.
In patients with subarachnoid hemorrhage from an aneurysm, why is it that higher cortical function is oftentimes impaired, although they seem to recover other things perfectly well, and yet a man who is a certified public accountant can only go back and do bookkeeping work, that sort of thing. What do you think happens in that circumstance?
Well, I think it's a very complex issue, really, and it relates partly, I'm sure, to the severity of the initial insult. Subarachnoid hemorrhage occurs in the majority of cases from vessels close to the base of the brain, and therefore you may have quite a profound disturbance of diencephalic structures, the susceptible problems of recent memory and so forth in relation to hypothalamus. And that type of thing can produce very considerable disruption of internal thought processes and yet be very hard to detect. It produces nothing in the way of long tract signs or anything of that sort. Right. And I think that probably explains it. You see it too sometimes, well, you see it transiently after removal of colloid cysts. You have a superficially absolutely normal chap, and yet he's not functioning at anything like his normal level for several weeks or even several months afterwards.
That's very true. What about the, what do you think about the reintroduction of stereotactic biopsy techniques in neurosurgery? Are you pursuing these?
Yes, we are pursuing this. I have a good colleague who, my senior lecturer, is a very avid stereotactic biopsier, and I think it has expanded our capacity to verify certain deeply placed lesions. I think that it will find its own place. I'm not certain that its place is as wide as people imagine it might be at the present time, but I'm sure it's an added capacity which we'll find very valuable. I think also it will be valuable if and when replacement of portions of tissue in deep nuclei becomes a practicable proposition. If one could demonstrate, for example, that it was worthwhile demonstrating or depositing fetal tissue in the basal ganglia, then that would be the way to do it. So I think the expertise is important to acquire.
It's interesting that the only patients with Parkinsonism that have had adrenal medulla implanted, the ones done stereotactically failed and the ones done open.
Yes, that's right. Well, I don't think that operation has really found its place yet. I don't think.
Well, I certainly agree with that. I don't know where it is or where it's going to be going. Tell me about pituitary tumors. Do you people routinely excise microadenomas of the pituitary for prolactinomas?
No, we don't routinely do that at all. I work in association with the endocrinologists at St. Thomas's Hospital and at several other hospitals in London. But the majority of young people with microadenomas are now treated by bromkriptine, at any rate for a time. There is, when one has a clear evidence of an expansion of the gland, then I think that the indications for surgery are probably stronger. And a good deal of transsphenoidal surgery is done for microadenomas in the United Kingdom, but I think people are a little bit hesitant to operate if the patient can be carried along on bromkriptine. I don't think the natural history of microadenomas is at all clear.
No,
you remember the work of Philip Wrightson, who in New Zealand did block dissections of a number of people who had passed on, and showed the presence of microadenomata in quite a number of pituitaries.
Very high percentage.
That's right.
Some series as high as 85%
That's right.
will have them. And certainly there are well-documented circumstances in which the microadenoma either stopped functioning or regressed.
Or regressed, exactly.
I have at least two patients in my own series who for a period of time got over their galactorrhea amenorrhea syndrome.
That's right.
And two of them actually conceived a child during this period of time.
Yes, well, I think these are the sort of things that will emerge with time, and there's no doubt that some people have been able to stop bromkriptine without recurrence of symptoms.
That I wasn't aware of. Turning to your own training program, could you tell us a little bit about the British system, the house officer, senior house officer, registrar, senior registrar concept?
Well, it's an interesting time to discuss the British training programs because we're at the present time trying to reorientate neurosurgical training. Up until now, the path of a young surgeon has been through general surgery. It has been necessary for him to do his postgraduate years as intern, registrar, or senior house officer, rotating through general surgical disciplines, and taking first the primary fellowship, which is anatomy, physiology, basic principles of surgery, and then a general fellowship in which he is asked questions about thoracic surgery, abdominal surgery, genitourinary surgery, orthopedics, and a bit of neurosurgery. For example, when they used to have written papers, when I was sitting at, one of the written questions I remember answering was how to do a ureterocolic anastomosis. An extraordinary thing for a neurosurgeon to have to learn. But we are now trying to reorientate this. You see, the young man would have to absorb all this information and then, when he got his fellowship, come into neurosurgery. He might have rotated through neurosurgery in the course of his training up to that time, but he wouldn't be able to concentrate on neurosurgery until he got his general fellowship. And what the society, in conjunction with the colleges, is trying to work out now is a scheme whereby the primary examination is retained and possibly slightly expanded to include the sort of general surgical principles that every surgeon ought to know. But the final fellowship is replaced by a specialist fellowship, which would be in neurosurgery or in orthopedics or in gut or whatever. And I think we are nearer to a consensus in this regard than we've ever been. The society set up a manpower and educational committee, of which I was chairman last year, and we devoted a good deal of time both to our manpower coverage of the country and also to the question of the reorganization of the fellowship, and I think it's coming.
Hasn't the Royal College of Edinburgh already proceeded to this direction, or did they back off from it?
No, they didn't back off. Under John Gillingham's presidency, they decided that they would establish a neurosurgical fellowship, and the original plan was that they would replace the final fellowship with a neurosurgical fellowship, but they didn't in fact do that. They just added a third examination. Oh. And as you can imagine, that was very, very unpopular with the trainees, and the majority of surgeons in Britain, of neurosurgeons in Britain, felt that it was not the right way to go. So that has been an examination which has really not taken off, although it has provided us with valuable experience as to how to run a final neurosurgical fellowship.
Yes, and what about the subject of manpower? Have the number of consultant posts increased?
They have gradually increased. It's been clear for many years that our neurosurgical coverage of the community was different from that in other countries, partly because of the relatively limited number of beds in neurosurgical units in Britain. It's never been the practice, for example, for us to take the primary care of head injuries. But with changing patterns of surgery, we are finding that our general colleagues wish us much more to be involved in primary head injury management. And also, of course, the orthopedic surgeons are finding their time taken up so much more with joint replacement and so forth that they are becoming unwilling to shoulder the load of spinal operations that they used to. With this, and with the fact that we feel the neurosurgical coverage has been a bit thin, the Manpower Committee and the DHSS have looked at this, and it's clear that we are going to have to expand the number of neurosurgeons very considerably.
DHSS?
That's the Department of Health and Social Security. These are our paymasters, usually, in the United Kingdom. And it's clear that that is going to, well, the project is that we will double the number of neurosurgeons in the United Kingdom from a present figure of 120 to somewhere about 200 within the next 10 to 20 years.
Really, that much? That's very interesting. Tell me, is private insurance and private beds becoming more popular in Great Britain?
Oh yes, oh yes. This is partly the result of the enormous shortages of money within the National Health Service, which are quite considerable. I don't need to go into detail, but the availability of some specialist techniques within the NHS is so poor that you may wait, for example, 6 months to get an MR scan, that sort of thing. That's not reasonable. And many more people have undertaken private health insurance schemes. And it's also been the principle of the British government that God helps those that help themselves, and therefore surgeons and patients have been encouraged to to attract, for example, overseas patients to the United Kingdom, or to insure themselves and go private.
Thank you very much, Professor Symon. It's been a pleasure talking with you.
Thank you very much, Dr. Clark.